So basically, we're going to be talking about HER2 positive disease. And we'll start with the case presentation. This is a 38-year-old woman who presents with a palpable left breast mass, 2.8 centimeter tumor, abnormal lymph nodes. The biopsy shows invasive ductal carcinoma grade 3, ER 60%, PR 50%, HER2 3+. The lymph node is biopsied as well and is positive for involvement with breast cancer. She has imaging performed and there is no evidence of distant metastatic disease. She arrives in your office to discuss the treatment plan. I am remiss in that I did not allow the rest of our panelists to introduce themselves and their affiliations, and so we'll interrupt here for a moment and we'll come back to the case. Anna?
Hi, I'm Anna Sandoval. I'm one of the breast medical oncologists at the Miami Cancer Institute.
I'm Kristina Mirabeau-Beale. I'm a radiation oncologist with Genesis Care in Southwest Florida, Fort Myers and Naples at our regional cancer center.
Hi, I'm Anthony Magliocco. I'm a molecular and anatomic pathologist at Protean BioDiagnostics-Orlando.
Well, thank you very much. I'm pleased and proud to share the podium here with a distinguished panel. So back to our case. So I just presented the case, and basically you have a young woman with a HER2 positive, a triple positive tumor, and a biopsy-proved axillary lymph node, and the PET scan showed no evidence of distant metastatic disease, and she's here to discuss therapeutic options. So she's 38. We've already said that. What would be your initial recommendations for treatment? So, Anna, as an aside, I'd just like to say we're faced with the situation of this young woman, and she obviously is an operative candidate. Would you be thinking more of neoadjuvant or adjuvant therapy?
So in a patient with HER2 positive breast cancer who has a tumor that is over 2 centimeters or positive lymph nodes, my recommendation will be neoadjuvant chemotherapy.
Thank you. Just a little bit of background about neoadjuvant therapy. This was the original Neosphere Trial. I believe it was presented by Luca Gianni several years ago. And basically, I got to move closer to see. The randomization here was Taxotere and Herceptin, Taxotere, Herceptin, Perjeta, Herceptin and Perjeta, and Taxotere Perjeta. So I'm not going to go through the data from this trial for right now because we'll move on to the second pivotal trial of neoadjuvant anti-HER2 therapy. And that is the Triphenia Trial. And here I don't want to go through, it's a very, very busy slide, and our next slide will give you results. So here we're talking about a randomization to FEC with Herceptin and Perjeta, FEC followed by Taxotere, Herceptin and Perjeta, and TCHP, a non-anthracycline-based regimen. And these are the results of these two pivotal trials, the Neosphere Trial and the Triphenia Trial. And in Neosphere, you can see that the best arm is Taxotere, Herceptin, and Perjeta with a pathologic complete response rate of 46%. One of the other interesting parts of this trial is the final result there with Herceptin and Perjeta. Although it's the lowest in terms of response rate, it's still rather remarkable that with a non-chemotherapy regimen, you are getting a pathologic complete response rate of 17%. The Triphenia trial is also interesting, and here you can see with a bit more aggressive chemotherapy, much better pathologic complete response rates. So with FEC plus Herceptin and Perjeta, followed by Taxotere, Herceptin, Perjeta, 61%. The one FEC without the Herceptin and Perjeta, and you remember that in the original clinical trials, there was a 28% rate of congestive cardiac failure when using an anthracycline with Herceptin, and so that's why this arm was included. And it was still a very good pathologic complete response rate, and they did not have an undue rate of congestive heart failure in that trial. And finally, TCHP with a 66% response rate. This slide is just to show the impact of pathologic complete response on outcomes in HER2 positive disease. And on the left, you'll see hormone receptor positive disease. On the right, hormone receptor negative disease. That's my right, and I guess your left, whatever. Anyway, the bottom line, and this is shown in all anti-HER2 trials, and that is that the overall response rates, pathologic complete response rates, are a bit lower in the patients who are triple positive as opposed to those who are hormone receptor negative and HER2 positive. So these are some considerations in neoadjuvant chemotherapy. It's appropriate, as Anna said, to offer patients with node-positive disease or tumors greater than 2 centimeters in size neoadjuvant therapy, and that's, I would say, probably the treatment of choice at this time. The most common regimens have been a source of consternation over the past 15 years, whether to use an anthracycline regimen or a non-anthracycline regimen. And it's caused an east-west block. I'm not talking about Russia, Ukraine, US. I'm talking about UCLA and Memorial Sloan Kettering Dana-Farber. And so, since I'm older, I'll go back to older data, which I pulled out of my slide set. Okay, so this comes from 2005, and these are the results of the BCRG 006 clinical trial. In that trial, patients were randomized to adriamycin cytoxan followed by Taxotere Herceptin. We didn't have Perjeta back then. Or adriamycin cytoxan without Herceptin. Or a novel regimen, a non-anthracycline-based regimen, TCHP, or TCH, sorry, no Perjeta. And here you can see that the overall survival of the two regimens containing Herceptin were superior to the non-Herceptin containing regimen. Well, this didn't convince anybody. The fact that there was a 1% maybe difference in overall survival, the people on the East Coast would not accept basically moving to TCH, and this was 15 years ago. And so one of the reasons was, well, you know, you got to use adriamycin if you got 4 more positive nodes. So you do the analysis. So this is the analysis of BCRG 006 with 4 or more positive nodes. And what you can see here, again, virtually no difference between the non-anthracycline containing regimen and the anthracycline containing regimen. So this is a little bit of history. This is 15 years ago, and for 15 years, the East Coast of the United States continued to use anthracycline-based therapy. Anna, since it's 15 years has passed, you're younger than I am, please, train.
So the Train2 study was a randomized trial that looked at this question again to an anthracycline versus a non-anthracycline containing regimen. Patients with a stage 2 or 3 HER2 positive breast cancer were randomized. And as you can see, there was really no difference between the anthracycline and the non-anthracycline based regimen. So you can see on the columns on your right, the primary endpoint was pathologic complete response, and the pathologic complete response was pretty similar between both groups. And in the bottom columns, you see, depending if they are hormone receptor positive or hormone receptor negative, as known, patients that are HER2 positive, hormone receptor negative have more pathologic complete response compared to the ones that are hormone receptor positive, HER2 positive. But both groups have pretty much the same pathologic complete response. Something that is not shown here, there was an updated analysis looking at event-free survival that was the secondary endpoint. And the 3-year event-free survival was pretty similar among both groups and was around 93%. Thanks.
Thank you. And after this, I saw an editorial from Dana-Farber indicating that they thought that at this point in time, there were few clinical situations where anthracycline-based therapy were recommended. So what about neoadjuvant chemotherapy in clinical practice, Anna?
So neoadjuvant chemotherapy is appropriate, as mentioned already, on patients that have tumors greater than 2 centimeters or are lymph node positive. The most common regimens are ACTHP or TCHP, but we favor TCHP as shown before. There doesn't seem to be greater benefit from an anthracycline-based regimen. When would I use an anthracycline-based regimen? Maybe in a patient that has some tumor heterogeneity. We have these patients that might have some percentage that is HER2 positive, but some of the tumor is triple negative, and we know that in those patients an anthracycline might help. But that would probably be the only reason, or if they have different tumors where I want to give an anthracycline. If not, I will probably give them, I will definitely give them TCHP.
Thank you. Okay, we'll return to our case presentation. The patient received TCHP for 6 cycles. Cycle 5 was delayed by a week due to thrombocytopenia. Overall, she tolerated the treatment well. She underwent bilateral mastectomies given her young age and a family history of breast cancer. She then underwent a radiation oncology consult prior to surgery to better understand the role of partial post-mastectomy radiation and the timing of her reconstruction and her adjuvant therapy. So, Kristina, it's all yours.
So this often comes up in clinical practice, especially with young patients. You know, there's a desire to want to de-intensify the radiation fields to minimize morbidity, especially in a patient who's undergoing reconstruction. However, at least at present time, the de-intensification of regional nodal fields is still under investigation. And I think I have a slide next of NSABP B51, which is basically specifically looking at patients who have lymph node positive disease, biopsy proven up front. They then complete chemotherapy, and HER2 positive patients are included on that trial. And then if they have a path complete response, they're subsequently randomized to radiation therapy. So if they've had breast conservation, the randomization is to whole breast radiation versus whole breast plus regional nodal fields, versus if they do undergo a mastectomy like our patient, it would be chest wall radiation alone versus chest wall radiation with regional nodal fields. And right now the experimental arm would be the de-intensification, so omission of regional nodal fields. But the standard of care still remains to treat comprehensive nodal fields. And the thinking there is a combination of historical data that shows significant local regional patterns of failure in the nodes in these patients, and we don't have modern data kind of currently showing patterns of failure now that we have more successful neoadjuvant chemotherapy regimens and such high path complete response rates. And then also, with regards to this patient in reconstruction, a lot of times this is why it's important to see patients in a multidisciplinary setting in conjunction with surgery and plastic surgery, because often, questions of whether we should do a delayed reconstruction, a more staged procedure with a tissue expander versus, for example, in a very young patient like this, if she had had very high burden nodal disease, just proceeding to, treating the patient without any reconstruction and then doing a delayed autologous reconstruction perhaps. So a lot of these factors have to be considered, and some of that's driven by surgeon availability and patient preference, as well as patient age. So all of those factors kind of come into play. And we didn't really have a slide on this, I think, but in terms of adjusting the lymph nodes, there can be false negative rates in terms of a negative sentinel node after neoadjuvant chemotherapy. And that's yet another reason why we favor kind of offering nodal radiation just in case there's microscopic disease to, again, increase the patient's local regional control. So that's just a schematic of the NSABP-B51 trial, which is yet to be published, but kind of describing the randomization, like I mentioned, in terms of omission or inclusion of regional nodes with the standard radiation field based on the patient's surgery. And then on the next slide, especially in patients who have left-sided disease, we've already kind of talked about the fact that, we're trying to omit anthracyclines. One of the main toxicities is cardiotoxicity. And then obviously with HER2 guided therapy, there's also a concern for cardiotoxicity. So when we factor in radiation as well, that's yet another area where we can have cardiotoxicity. So at least in terms of radiation field, several techniques and things that we can do kind of upfront in designing our treatment portals to make sure that we're minimizing cardiac dose and thereby minimizing long-term toxicity. This has made it into the NCCN. That's an old version from 2019, but it's kind of iteratively been updated that basically it's standard of care to factor in cardiac sparing techniques, whether that be, like in the upper right, we have a patient being treated in the prone technique. This works for patients who are being treated to an intact breast, especially if it's above a certain size, pendulous enough to kind of hang beneath our table. And we have a special immobilization that allows the breast to kind of be under the table so that all the mediastinal structures are secure and not exposed to any radiation. Versus for patients like this index case who have lymph nodes involved, when we have to treat the lymph node fields, especially after a mastectomy, prone isn't really an option, but we can do deep inspiration breath hold. And so in the bottom left, we have a comparison of kind of the proximity of our radiation field. So that's a dose cloud view, where you can basically see how the red area, or the high dose field, gets very close to the heart during the free breathing, which is basically a volume average of the patient breathing through respiration. Whereas when a patient takes a deep breath and holds it, as the lungs fill, it pushes the mediastinal structure somewhat down, and we get more separation from the heart, allowing us to really gate our radiation beams and treatments to make sure that we're sparing heart dose. And then yet a third option is protons. If your institution has that as a technology, that's particularly beneficial for patients who are young, like this case, patients who may have a transplant, and I've had a few of those cases where I refer them for protons to really minimize extra heart dose. And then of course patients where we're treating complex anatomy with maybe a large chest diameter or separation, and as well as trying to include the internal mammary chain. Some of our more historical techniques involve kind of doing matching of superficial radiation electrons to the internal mammary chain compared with photons for the chest wall, but I think protons is a more elegant solution if you have that at your institution or within a radius to carefully refer patients. And then that too can be coordinated with their reconstructive efforts.
Well, thanks so much, Kristina. So anyway, we go on with our case presentation, and she goes to surgery. She has no residual disease in her nodes, but evidence of treatment effect in 2 nodes. What? Okay. So basically, it was evident that we know that she had disease in the nodes before. We now see that there's no residual disease in the nodes, but you see that the chemotherapy has left its impact on the nodes. In the residual tumor bed, there is 1.2 centimeters with 60% cellularity. So the patient did not achieve a pathologic complete response. So at this point, I'd like to ask Anthony to perhaps say a little bit about the pathology of HER2 therapy and disease.
Sure, thank you. So Her2 testing has been around for over 20 years now, and has evolved a bit over time. Here's the conventional way of scoring HER2. It's immunohistochemistry. You get a score from 0 to 3+, based on the intensity and the visualization of that done in a microscope. There is also, in the group of 2+ and 3+, there was generally a reflex to in situ hybridization to look at the gene copy number. The gene is called ERB2, also known as HER2. The protein is called HER2. The gene copy number is counted and the ratio determined. If the ratio is above 2+, it's considered amplified. If it's below 2+, negative. There was a period of time where there was an intermediate or indeterminate category, but that's been somewhat eliminated with that. More recently, there's some interest in this new category of HER2 low, which is really HER2+ without amplification. So we'll go to the next slide, please. So one of the complications of HER2 assessment is that it's frequently heterogeneous, in that you can see regions where there is areas of 0 staining, areas of 3+, areas of 2+, areas of 1+. And this can be somewhat problematic if you have a small biopsy. You may think that the tumor is a HER2 negative tumor, but there could be areas where it is HER2+ in other parts of that tumor. And there's some question as to whether you should repeat staining if you do have a small biopsy that's negative. And repeating is always warranted in that you may be missing an area of heterogeneity. So we'll go on to the next slide. We're stuck.
I'm pressing real hard.
Yeah, there's a commentary. I just put in a slide. I'm from Canada. Back about 15 years ago, there was a major national concern in Canada about the quality of HER2 and estrogen receptor staining when it was determined that one of the Canadian provinces had done incorrect staining for over 10 years, and it affected hundreds of women, giving them incorrect results. So this is also to remind us that labs are important and that quality of staining is important, and errors can occur as well, so one needs to be aware of that fact. Next slide. The Globe and Mail is the national paper in Canada, so it was on the front page of the paper for a long period of time. No one cared about pathologists until this happened, and they were in the news every day. So this prompted a national survey on the quality of HER2 testing in Canada, where labs were compared to one another, and what we see here is the results. Each column is a different lab, each row is a patient, and the scores are indicated. A red score is a 3+. The other scores are different scores. Green was 2+, and blue 1, white 0. And you can see while there was substantial concordance of over 90%, there actually is variation between labs, and that some labs will call some stains 2+ and others 3+. So that's also something to keep in mind as we try to improve the quality of lab services for this type of measurement. Next. So that's the pathology review.
Okay, thank you. So the patient goes to surgery, and she has, let's see, that's a repeat. She has residual disease. It's ER 90% positive, 74% positive, 2+ positive by IHC, but FISH positive with a ratio of 3.4. And so at this juncture, the question is, in the past, we've just continued with Herceptin and Perjeta, and then there was a seminal trial, the Catherine trial, and I'll turn it over again to Anna.
So I think the Catherine trial changed the standard of care for this type of patients. This trial looked at patients that had neoadjuvant chemotherapy with trastuzumab and had residual tumor in the breast or in the lymph nodes. and they randomized them to either T-DM1 or trastuzumab. At that point, pertuzumab was not a standard. And we can look at the next slide. And there was an improvement of invasive disease-free survival, as you can see here, from at 5 years, from 77% to 88.3%. So this really changed the standard, and now any patient that has a residual disease after neoadjuvant chemotherapy, my recommendation will be to consider T-DM1. The next slide. So as I mentioned, this definitely changed our practice. Just a few small caveats. Patients that were on the T-DM1 arm had more side effects, and 18% of patients had to stop the medication. They allow patients to go back to trastuzumab. Usually if my patient is not tolerating it and we have to stop, I will complete the year with trastuzumab and now with pertuzumab. And the financial toxicity is a real issue, especially in uninsured patients or in countries where they don't have so much resources as we have. Next slide.
I'm sorry about the slides.
So I didn't talk about adjuvant pertuzumab because this patient had a complete pathologic response. But since we now routinely we incorporate that in our neoadjuvant approach, the affinity study looked at adjuvant pertuzumab, and they found improvement in progression-free survival. So if the patient had a complete pathologic response, I will have recommended to continue pertuzumab, especially if they are node positive. There is a new drug that was approved in 2020, that's Phesgo. We call it a pandemic drug because it's helping patients to just go for a subcutaneous injection that is a combination of trastuzumab, pertuzumab, instead of spending a long time in the infusion. And the Federica study showed that the Phesgo, looking at the levels of Phesgo, was very similar to the levels of pertuzumab IV.
So we're back to the case presentation again. She completed her radiation therapy, she completed Kadcyla, and given the fact that she is estrogen receptor positive, she also requires endocrine therapy. So how do you initiate this discussion, and what and when do you start hormonal therapy?
So I routinely will discuss the treatment plan with the patient when I originally see them. Sometimes if I see them too overwhelmed, I tell them during their treatment, but I try to let them know that they may need additional therapy, and this may be a long journey, because if not, many times by the end they don't want to continue with any treatment. She's 38, she's premenopausal, so I will probably offer ovarian suppression with an aromatase inhibitor. We just saw in the last discussion the SOFT and TEXT trial showing an improvement in outcomes in patients that are high risk. Having said that, it's only 12% of patients were HER2 positive in that study, so I don't think there is a lot of data for triple positive breast cancer, but I will still recommend this to my patient. I usually start with T-DM1, since in the Catherine trial they allow starting endocrine therapy concurrently with T-DM1.
Okay, at this point we have a plethora of really good drugs for anti-HER2 targeting, and Neratinib is another of those. And perhaps now maybe you can tell us what your view on Neratinib might be.
So after completed, in this case, T-DM1, I will offer this specific patient Neratinib, and this is based on the results of the ExteNet study that looked at Neratinib versus placebo in patients with stage 1 to 3 breast cancer. Originally, they allow node positive and node negative, and they allowed patients to be randomized if they completed trastuzumab within 2 years. But as you can see, there was later an amendment that only allowed patients that had node positive disease and who completed the treatment within 1 year. Next slide. Neratinib show a small but significant improvement in invasive disease-free survival at 5 years from 87.7 to 90.2%. And next slide. And when they look at the different groups, they saw that patients that were hormone receptor positive were really the ones that benefit. There is the chart in the Kaplan-Meier curves on the left shows you the benefit in that group, and as you can see, the hormone receptor positive negative patients did not benefit.
Okay.
Next slide.
I just got a clue.
So this was a recent publication. They did a further subgroup analysis, but this is important to know that these are very small number of patients, but they were trying to find which patients are the ones that are benefit the most from adjuvant neratinib. And they look at the hormone receptor positive cohort, but specifically the ones that started neratinib within 1 year, and they seem to be the group that benefit the most, with an improvement of like 5.1%. And on your right, you can see that patients that did not achieve a complete pathologic response, so this will be like our patient, they had an even larger improvement of 7.4%. But it's important to note that this is subgroup analysis. One caveat with neratinib is the diarrhea. In the Extended trial, around 40% of patients had grade 3 diarrhea. So the control trial looked at different ways to decrease the diarrhea in this patient population. And now the standard is to start neratinib at a lower dose and titrate up. So you usually start week 1 at 120 milligrams per day. Then you go on week 2 to 160 milligrams. And then at week 3, if the patient is tolerating it well, you can go to the full dose of 240 milligrams, and you continue throughout the treatment. And in the control trial, the number of patients that had grade 3 diarrhea was around 13%. So we know this works with patients, and you always tell patients that if they have any evidence of diarrhea, to start loperamide as soon as possible. And so it's try to counsel patients, and then you had other options if they, despite all this, they continue to have diarrhea. So adjuvant neratinib we consider for locally advanced patients with hormone receptor positive, HER2 positive disease. And based on the most recent data, we try to start early, like within a year from them completing adjuvant therapy. We try to bring them up early to patients, as I mentioned, so to try to avoid the treatment fatigue. A caveat of this is that none of these patients receive pertuzumab or T-DM1, so we really don't have a lot of data what to do with these patients, but we know, as shown before, that patients that do not have a complete pathologic response don't have the best outcome. So if the patients are tolerating well and are willing to continue and we are able to control the diarrhea, I think that it's good to give them more options that will possibly give them better outcomes.
So ultimately, the patient started neratinib at 120 milligrams, and she's able to titrate up to 200 milligrams with the help of Imodium. She stays on ovarian suppression and an aromatase inhibitor at the same time. How would you monitor her? What do you say to a patient who asks about scans, ctDNA testing, tumor markers? What do you say about that?
I think they discussed also this in some degree in the prior panel. The NCCN guidelines do not recommend to follow them with tumor markers or do a scan. So my way of monitoring, I see them every 3 to 6 months for their physical exam, regular labs, and if there is any abnormality, then that will order scans depending on their symptoms or their complaints. I don't think ctDNA is ready for prime time, but I think this is a tool that in the future we'll probably start using. And we have a lot of trials looking at this to see which patients need additional therapy, and maybe we'll have it will be useful also for the escalation. But I think all of this is still under investigation.
Anthony, I don't want to blindside you, but do you have any uptick on the ctDNA testing as a way of following these patients now?
Yeah, actually, ctDNA and circulating tumor cells and cell-free DNA have been around for a period of time. There's extensive usage of CTCs back about 15 years ago. And they were sort of discontinued, although they're now back in investigation again. One of the value of circulating tumor cells is that you can visualize protein expression in them, where you can't really see that in the circulating tumor DNA. So you can actually, if there are circulating tumor cells, determine if they are becoming HER2 positive or becoming HER2 negative or even estrogen receptor positive. So again, this is an experimental area and we're really able to monitor that. With the cell-free DNA, again, you can also monitor whether there's a residual tumor that's present either with passenger mutations or with targetable mutations such as potentially PIK3CA mutations or amplification of HER2 or other potential targets. But again, these are currently in the investigational stage, but I expect to see more use of them going forward.
Thank you. But she does well on ovarian suppression and AI for 2 years. She completed Neratinib, and then she started to develop a cough. Imaging shows metastatic disease in the lungs and the liver. Biopsy of a lung lesion shows metastatic breast cancer. It's ER 40% positive, PR negative, and HER2, again, 3+. So, Anna, what would your current management be? Any clinical trials you're excited about?
So since it has been already 2 years from the time that she completed adjuvant therapy, I will probably re-challenge her with the taxane, trastuzumab, or pertuzumab. Although it's important to mention that we really don't have enough data to know what to do on this patient that had already received T-DM1 and Neratinib on the adjuvant setting. But I think it's still worthwhile doing, trying again the taxane with trastuzumab and pertuzumab. Trials that are currently ongoing, there is an energy study looking at atezolizumab in combination with trastuzumab and pertuzumab and chemotherapy. I think that might change our management in the future, but it's still ongoing. And then we have DESTINY-Breast09 that is looking at trastuzumab deruxtecan in this specific setting. So these might be trials that will change our management in the future, but they are still ongoing. For now, this is just that graph was just showing how trastuzumab improved outcomes in 2005 when it was originally presented versus a taxane regimen, and the progression-free survival went from 22.7 months to 31.2 months. And then the Cleopatra study showed that the additional of pertuzumab to trastuzumab improved also progression-free survival. We can look at the next slide. And as you can see, there was an improvement of the median progression-free survival from 12.4 months to 18.5 months. Next slide. And also an improvement of overall survival from the 3-year overall survival being 50% in the trastuzumab alone with the taxane versus 66% in the patients that receive additional pertuzumab. So that is the standard first-line regimen for patients with HER2-positive breast cancer, I will say. So it will be a taxane with trastuzumab and pertuzumab. You can not necessarily use only docetaxel. The per-use study looked at different taxanes, including paclitaxel and nab-paclitaxel, and they were pretty similar in terms of efficacy. I usually, in the studies, they stop the chemotherapy backbone, and then you continue the trastuzumab, pertuzumab until the patient progresses.
So she does well after THP induction, the Cleopatra regimen, and continues on Herceptin and Perjeta maintenance for 18 months. She then develops progression in the liver and lung. So would you do brain imaging at this time if asymptomatic? And I'll address that to Anna and Kristina. And what would your second-line treatment be, and what would that change if she had brain metastases? So let's start with Anna.
I don't routinely do brain imaging in these patients, even though we know a big number of patients will develop brain metastases. It's not still in the guidelines. Having said that, they might change in the future because we know a lot of these patients will develop brain metastases, and we know there are drugs that we can use in patients with active brain metastases. But I have a very low threshold of ordering brain imaging in this patient population. I don't know what you do, Kristina.
Agree. So in our institution, similarly, just a very low threshold to order brain imaging for, even very subtle symptoms. But it's not routinely part of either surveillance imaging or, at times of systemic progression to then reflex to CNS imaging.
Okay, so now we're back to Anna, and what would your second-line treatment be at this juncture? And then we'll have an interchange also again with Kristina. And how would that change if she had brain metastases?
So trastuzumab deruxtecan was approved last year for this specific, in the second-line therapy. Trastuzumab deruxtecan is an antibody-drug conjugate that has a humanized anti-HER2 antibody similar to trastuzumab, a topoisomerase 1 inhibitor, that's the chemotherapy, and a tetrapeptide-based cleavable linker. It's different from TDM1, where because TDM1 has a microtubule inhibitor as a chemotherapy, trastuzumab deruxtecan has a very high drug-to-antibody ratio. It has a cleavable linkage and has a membrane-permeable payload. It's a very potent drug. Next slide. It was originally approved on the third-line setting based on the results of the DESTINY-Breast01. This was a phase 2 single-arm looking at different doses of trastuzumab deruxtecan, and the primary endpoint was overall response rate. And next slide. And this was an impressive waterfall plot showing an overall response rate in this very heavily pretreated population of 62%. Patients had the median line of therapies were 6, so these patients had received a lot of therapy, and from prior studies, usually the overall response in this patient population is low. And even with this heavily pretreated population, the progression-free survival was 19.4 months. So this led originally to the approval of trastuzumab deruxtecan in the third-line setting, but then we have the results of the DESTINY-Breast03, next slide, which was a randomized phase 3 study looking at trastuzumab deruxtecan in patients that had progressed after taxane and trastuzumab. So it was a second-line therapy compared to TDM1, and they were randomized in a 1-to-1 ratio. As you can see in the bottom right, all these patients received trastuzumab, some of them received TKI, and the majority received also pertuzumab. This was the primary endpoint, progression-free survival, which was the 12-month progression-free survival was 75.8% versus 34.1% in the TDM1 arm. Next slide. And there was also an improvement in overall survival. And as you can see, there was a response rate of 79.7% compared to 34.2%. So this really changed the guidelines, and now is listed as the second-line therapy for patients with HER2-positive metastatic breast cancer. So what about brain metastases? I'm going to talk a little more about the HER2 climb. The DESTINY-Breast03 allowed patients with brain metastases, but they had to be stable and treated. They did not allow patients with untreated brain metastases. And this was presented in San Antonio in December. And they did a subgroup analysis looking at these specific patients who had brain metastases. As you can see, the numbers are not that much. There are 16% in the T-DXd arm and 14.8% on the TDM1 arm. Next slide. So they look at a progression-free survival in these patients. And as you can see on the left Kaplan-Meier curve, patients with brain metastases at baseline also had benefit from T-DXd compared to TDM1. Next slide. And they also look at the intracranial response rate in these patients with treated and stable brain metastases, and they also found, I believe the overall response rate in the T-DXd arm was around 60% versus around 30% in TDM1. So we know there is some activity, but as I mentioned again, these are patients with treated brain metastases. The main concern with T-DXd has been pneumonitis, ILD, In the DESTINY-Breast01, there were around 2.8% of patients that developed a grade 5 and died from the pneumonitis. Luckily, in the DESTINY-Breast03, I think now we know what to expect, and we educate our patients that if they have cough, shortness of breath, to reach out to us, and we have a very low threshold of ordering scans and starting steroids. And with that, in the DESTINY-Breast03, the grade 5 pneumonitis was 0. Ducatinib, so as we mentioned before, in a patient with brain metastases, Ducatinib has shown to be active even in patients with stable, with untreated brain metastases, I mean. Next slide. So Ducatinib is a HER2 selective TKI. The Her2 CLIMB was a pivotal trial of Ducatinib, trastuzumab, and capecitabine versus placebo, capecitabine, and trastuzumab in patients that had a HER2-positive metastatic breast cancer who had progressed after T-DM1, and they were randomized in a 2-to-1 ratio. And in the bottom left, you just see a graph showing the specificity of Ducatinib versus Neratinib, and for that reason, diarrhea is not such a big problem with this drug as compared to Neratinib. As I mentioned before, this trial, what differentiates for others is that it allowed patients with active brain metastases. 48% of the patients had brain metastases. Of these, 40% had a stable, and 60% of these patients had active brain metastases. And when they look at the active brain metastases, 23% had untreated, progressing brain metastases, and 37% had treated, but they were progressing when patients were enrolled. Next slide. It showed in the overall population improvement in progression-free survival from 5.6 months to 7.8 months. And next slide. And here you can see the updated overall survival from 19.2 months to 24.7 months with addition of Ducatinib. Next slide. And when they look at the patients, and this is, it's beautiful to see that how much these patients with active brain metastases respond to this drug. There was a 47% overall response rate in the patients with active brain metastases compared to 20% in the placebo arm, and there was an improvement of both progression-free survival and overall survival in these patients with active brain metastases.
So the patient underwent brain imaging, and she had no central nervous system disease. She started in HER2 and has GI toxicity, alopecia, fatigue, but no interstitial lung disease. After 14 months, she progressed again. This time, she has several small brain metastases. Plans are made to transition her to trastuzumab, capecitabine, and Ducatinib. So what would make you want to do radiation here versus no radiation? What radiation approach would you take? So Kristina, you want to handle that?
So our two main techniques when it comes to handling CNS disease are whole brain radiation versus stereotactic radiotherapy. So with stereotactic, we're basically treating usually in a single fraction, though for sometimes larger lesions, so 2 to 3 centimeters, we can do, let's say, 3 fractions or even 5 fractions. But the goal with stereotactic techniques is to be very pinpoint and to target the lesions and spare the intercalating brain to minimize the morbidity of whole brain, so things like fatigue and cognitive deficits. And especially in patients like this that have multiple different systemic therapy lines that they can progress through, their life expectancy we're optimistic about, and so we'd like to minimize the long-term morbidity, especially of cognitive deficits. But a lot of this comes down to our both technology and then imaging resolution. So, when I hear several small brain mets, I'd want to know an exact number and a geographic distribution, because it's very different if the person has more miliary disease where that actually may be better treated with either a change in systemic therapy with something that has better CNS penetration like Ducatinib versus whole brain, as opposed to someone who may have 2 or 3 small sub-centimeter brain lesions. which actually goes back to our earlier point of should we be surveilling these patients or not, because often when you do surveillance MRIs, you're more likely to find smaller lesions that are asymptomatic and are more amenable to easy treatment with stereotactic and minimal side effects. So for her, I think, she also has systemic progression, it sounds like, so she's at a crossroads. I think if she had fewer than, and that's the other point, how many lesions is too many to offer stereotactic? There are actually randomized studies looking at treating up to 10 different lesions, especially if they're small. And from a technique perspective on our machines can be treated with a single volume, so a single isocenter, because in that situation, the patient can actually be treated in a single session, and we can still give high-dose radiation to each of those lesions, and then save whole brain radiation as a salvage, or save switching the patient to Ducatinib as a later salvage option. So I think at this point it's a multidisciplinary discussion. It also depends on her performance status. She's been having a lot of other side effects from her treatment, so what does the patient want to do? But it could be an option to offer stereotactic radiotherapy, especially if she only has a few lesions, versus switching to something like a Ducatinib-based regimen and then surveilling her in a shorter interval and then seeing how the CNS changes.
Anna, would you like to say anything about?
I think if she's asymptomatic and she has a few brain metastases, and based on the results of Her2 Climb, looking at these patients with untreated brain metastases, as Kristina said, we can consider withholding radiation and just switching to therapy to Ducatinib and monitoring, and then if progression, then giving them radiation. I think that could be a good option. I don't know what you think.
No, that's fine. After 6 months, systemic disease is stable, but the brain metastases increase in size and 2 more develop, 5 lesions now. Should radiation be considered? What would be the approach? Would we switch systemic therapies or stay the same? And options in later lines. Kristina?
So I think the radiation question is more clear here. I'd consider treatment. And with 5 lesions, especially if they're each less than even 1.5 centimeters, you could safely treat with stereotactic radiation with a single session. Larger lesions, arguably, that would more look like a whole brain picture. So it would depend on the size and specifically the symptoms of the patient. But in this situation, I think stereotactic radiation would be appropriate.
Anna, would you switch systemic therapy?
I usually do not switch if the brain, the brain is treated and there is no evidence of systemic disease outside the brain. So I will continue with the same regimen and continue to monitor with MRIs the brain and the systemic and the scans, and then at the time of progression, then I will switch definitely regimens. And based on what options in later lines, I think for this we have a lot of different options and not a clear answer to what to use. We have margetuximab that was approved based on the SOPHIA study. That's another antibody, a monoclonal antibody similar to trastuzumab. This patient had a hormone receptor positive and HER2 positive disease, so we could also target the hormone positive. There was data from the Monarch Her looking at fulvestrant with trastuzumab plus abemaciclib versus trastuzumab and chemotherapy of physician choice, and there was an improvement in outcomes in patients with a fulvestrant, abemaciclib, and trastuzumab. So that could be another option in the future for this patient, or any combination of trastuzumab with a chemotherapy backbone. So I think we have a lot of different options. Or if you have a clinical trial, obviously that will be the first recommendation for this specific patient.
Okay, we've got a couple of minutes. In conclusion, we've made extraordinary progress in the management of HER2 positive breast cancer, and I think that Jane did a fantastic job navigating us through all of these different relapses and able to show off all of the new advances in anti-HER2 therapy. In early stage disease, the ability to use pathologic complete response to define progression and predict response to treatment, that's an advance. Options like adjuvant TDM1 to salvage patients who do not achieve pathologic complete response, and now we have and HER2 to challenge TDM1 in Catherine-2 or whatever name of the protocol you want to call it. In metastatic disease, we have a large arsenal of viable options, several of which are improving outcome for patients with brain metastases. Many trials are ongoing and in development. So I think at that, we've
Chuck,
finished.
we have some great questions through the app. If you don't mind, I'll just
No, not at all. Go ahead.
Yeah. So some really good questions coming in through the app. So this one, Anthony, I think you can hopefully help us out with, and this is something that comes up sometimes as we're trying to adjudicate HER2 results. So we have a patient with breast cancer who's HER2 positive on IHC, but then for some reason basal on mammoprint blueprint. So blueprint, the 80 gene assay, which looks at intrinsic subtyping. So I'm not sure why that would have been sent in the setting of clearly a HER2 positive tumor, but say it is sent. And how do we use intrinsic subtyping to adjudicate these results if there is a situation where it is unclear, and should we be doing that?
Well, the strongest evidence is based on the IHC, that's the first line level of assessment. So I would always go by the IHC and the ISH as the initial assessment. I take that into account if I found a molecular phenotype that suggests it was a basal or something else, that this could be a heterogeneous tumor or mixed phenotype tumor. So that's something to be considered as well. There's also the outside chance that you also have a problem with mixing up the specimen. So you always got to consider that. Did you actually send the right specimens for analysis? Retesting is always an option when you have a concern as well, particularly on the IHC side. So there's a number of things you could do in that situation.
And what I would say is that if it was adjudicated and it came out exactly the same, this would be one of those situations where I consider using anthracycline-based therapy in order to cover presumed heterogeneity.
Great, thank you. So there are two questions that I'll actually summarize. Do you check HER2 by IHC and or FISH on residual tumor after neoadjuvant chemotherapy? And the next one, which is along the same lines, is I wish to ask a question about management of residual disease in the setting of a patient who was HER2 positive at the time of neoadjuvant, at the time of residual disease found to be HER2 negative. I don't know who wants to take that question.
Well, I can start from the pathology point of view.
Yeah.
Is that it does make sense to test the residual disease. It could change, so you can see instances where it was HER2 positive and now it's HER2 negative, and that can be important. In some instances, it could go the other way around as well, where it could become HER2 positive. So we know about this category of heterogeneity in the tumor, but also tumors can change categories as well. So you certainly could consider doing the retesting in that situation, but I'd turn it over to my medical oncology colleagues as to what they do with that information.
Anna?
I don't think we have a clear answer of what to do with these specific patients. I believe in the Catherine trial, they did not look at the tumor after they have a complete after they have residual disease. They don't look back there. But I think they have the specimens and they're looking back to see if these patients will still benefit from TDM1 or not. I think it's a tough question.
There actually was a small analysis. Sybil Loy presented this back at, I think, ESMO in 2020. There were about 70 patients. It was about 8% of the total group that had residual disease that was considered HER2 negative. And in this group, there were no IDFS events among patients randomized to TDM1, and there were 11 events in patients randomized to trastuzumab. So that actually, I guess, brings up the question of should we be retesting because the benefit of TDM1 was still shown there. And in my practice, if I was faced with that situation, I wouldn't withhold TDM1 in a patient that was clearly HER2 positive to start with. So let's get back to the app here and see. Kristina, this is a question for you. For a clinical T2N0 patient who had neoadjuvant chemotherapy with a PCR at the time of mastectomy, would you consider adjuvant radiotherapy?
That's an area of controversy. You know, there's some studies looking at kind of high-risk node-negative patients and the benefit of post-mastectomy radiotherapy. But I think specifically for this lady, she was in her late 30s. You know, I think we'd like to probably avoid the morbidity potentially of a secondary malignancy and long-term toxicity from radiotherapy. So I think with T2N0 disease, you know, maybe we would do an axillary ultrasound to make sure there was no occult lymph node disease. I would omit radiation post-mastectomy.
Thank you. I think this is a great question. We didn't raise this issue in this patient, but would genetic testing be considered in this young patient with a family history, though HER2 positive?
Absolutely.
Yes.
Yeah.
Even without family history, I will, because of her age, I will recommend genetic testing.
And then in the last minute or so we have, I like this question, what neoadjuvant chemotherapy regimen would you consider for an elderly, frail patient? This comes up quite a bit here in Florida with HER2 positive disease.
So you can, there is some data of TDM1. It was not better than chemotherapy with trastuzumab and pertuzumab, but still I think that's an option for an elderly patient. And you can also give them a taxane with a trastuzumab and see how they tolerate. So I think you have some options for this specific patient. And as you saw in the studies, trastuzumab, pertuzumab alone, there was a complete pathologic response in a number of patients. So if you really think she's not going to tolerate TDM1 or chemotherapy, you can give her just trastuzumab and pertuzumab, plus endocrine therapy if she's triple positive.
Chuck, do you have anything to add?
Yeah, if she was estrogen receptor positive, use an anti-hormone with trastuzumab, pertuzumab.
Okay.